Welcome to the What Pediatricians Need to Know About Latent Tuberculosis Infections. Today's presenters are Drs. Sabah Kalyoussef, Kristina Feja, and Dr. Peter Wenger. Dr. Sabah Kalyoussef is a pediatric infectious disease attending and hospitalist at the Children's Hospital at St. Peter's University Hospital. She completed her fellowship in pediatric infectious disease at the Children's Hospital at Montefiore and her pediatric residency at the Children's Hospital at St. Peter's University Hospital. Dr. Kalyoussef is a clinical ID physician interested in educating the community and physicians on LBTI screening and treatment. Her interests include general ID, immunocompromised hosts, and TB. Dr. Kristina Feja is the chief of the Division of Pediatric Infectious Diseases at St. Peter's University Hospital in New Brunswick, New Jersey. She completed her fellowship in pediatric infectious diseases at New York Presbyterian Hospital and her pediatric residency training at Metro Health Medical Center in Cleveland, Ohio. Dr. Feja has a strong interest in tuberculosis and also works at the Department of Health Middlesex County Tuberculosis Clinic. Dr. Peter Wenger is an attending physician in the Department of Pediatrics at the Children's Hospital at St. Peter's University Hospital. Dr. Wenger completed his fellowship in pediatric infectious diseases at the University of Medicine and Dentistry of New Jersey Medical School, and his pediatric residency at Case Western Reserve University in Cleveland. Dr. Wenger also works at the Department of Health Hudson County Tuberculosis Clinic. Without further ado, I'd like to turn the presentation over to Dr. Sabah Kalyoussef.
Thank you, Courtney, for that introduction. I just want to double check we're also getting MOC points, correct, for our listeners?
Yes, that is correct.
Okay. Well, good afternoon, everyone. Thank you for joining us today. I hope you take away a few points from today's presentation. We're going to talk about screening for latent tuberculosis infection in children. We formed an education working group this past June with my colleagues here at St. Peter's, the Rutgers Global TB Institute, as well as the New Jersey Department of Health and the AAP as we bring you this presentation today. I have nothing to disclose. And just an outline of what we're going to talk about today is definition of latent TB infection, the epidemiology of TB disease and latent TB infections in the global, national, and local scale. I'm talking about screening, diagnosis, treatment, the BCG question that we all have, window prophylaxis, billing, and resources for physicians and patients that you will get at the end of this lecture. Latent TB infection, or LTBI, as I'll use for the rest of the presentation, is the presence of mycobacterium tuberculosis organisms without signs and symptoms or radiographic or bacteriologic evidence of TB disease in children less than 15 years old. And I think this is sometimes a nice graphic to use with parents to explain latent TB, is that it's present, but it's dormant versus TB disease, and why it's important for treatment. As we know, TB exposure is latent TB reservoir. So a person gets exposed to mycobacterium tuberculosis, and 5% of those patients actually develop active disease, while 95% of them develop latent TB infection. And only of those, 5 to 15% have reactivation. And we know the highest risk of TB infection is actually the first 2 years of exposure, but it's really the first 6 months that's the highest risk. And this is taken from the WHO. Or World Health Organization. I thought we'd start with a case that Dr. Feja saw that would kind of keep us in line in terms of what we're discussing today. So we have a 14-year-old boy that moved from India in 2015. His grandmother was sick 1 month prior to moving. And upon history, the grandmother was diagnosed with tuberculosis and treated for 9 months. She had active disease. And in April of 2015, his TST was positive, or tuberculin skin test was positive, his chest x-ray was negative. And at that time, the pediatrician did not recommend treatment, despite the fact that the child, by definition, met a latent TB infection and met requirements for treatment. June of 2017, 2 years later, he developed 2 weeks of fever, 103 to 104, with chills, fatigue, night sweats, decreased oral intake, and weight loss. And he was diagnosed with a right supraclavicular and mediastinal lymph node tuberculosis infection, disease, that was pyrazinamide resistant. Now, unfortunately, this child had a long, a complicated course. About 2 months into treatment, he went on to develop immune-mediated paradoxical reaction with worsening symptoms. He developed new left supraclavicular lymph node, a massive enlargement of the mediastinal lymph nodes, and new lung infiltrates. And this was thought because of the waking up after prolonged suppression from his TB disease and not a failure of therapy. He required multiple drainage of his necrotic left supraclavicular lymph node, as you can see in the picture, and in the end required weeks of steroids in addition to TB medications, which obviously are cumbersome. And he also developed hepatitis that required stopping his medications for a week and restarting. And in the end, he was treated for 9 months of treatment. And all of this was preventable if he received his course of prevention of medications for his latent TB infection 2 years prior. Now, when we look at tuberculosis, latent TB infection has become an increased priority for the World Health Organization, WHO, and the Center for Disease Control and Prevention, the CDC. We've become a global village, as you can see in this picture, as travel has increased. Newer drugs offer shorter treatment regimens for latent TB infection, and the treatment for latent TB infection is part of the global TB elimination strategy by the WHO. When we look at the global epidemiology of TB disease in adults and children, it's one of the top 10 causes of death globally. It's a leading cause of death from a single infectious agent, a major cause of death due to antimicrobial resistance. It's a leading killer of people living with HIV. And when we look at the HIV-infected individuals, they account for 9% of the total TB cases, and 72% of those reside in Africa. 2/3 of the cases occurred in 8 countries, and I bolded India because most of our population in Middlesex County that we see are travel frequently to India, followed by China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. When you look just specifically for children, 1 million cases of tuberculosis disease is in children. And there was 233,000 tuberculosis-related deaths in children less than 15 years of age, as was the definition for children in 2017, as reported by the WHO's Global TB Report in 2018. And when you look at the latent TB infection prevalence rate globally, as measured in 2015, it's about 2 to 3 billion persons with LTBI globally, or about 1 in 3 persons. There's another study that suggested 25% on a recent update using AGRA testing as well. And recently we found an article that showed that it's estimated that 1 in 1,000 people have MDR-TB, latent TB infection. When we switch to our our national level, we have the epidemiology of TB disease in children and adolescents. A recent article by the CDC looked at our national tuberculosis surveillance system data from 2007 to 2017, and the tuberculosis disease cases in U.S.-born children were 76% of the 3,800 cases of TB disease in children less than 15 years of age, and 42% of the 1,200 adolescents and 15 to 17-year-olds. And it's close to half of the infected children were in Hispanic U.S.-born children, which I thought was interesting because remember, we're going to speak about the risk factors of our patient population. And if a child was born outside the United States, the TB incidence rate was 12.9 times higher than a U.S.-born child. And these were mostly in children who came from Africa and Oceania. In terms of looking at the United States, latent TB prevalence in adults and children, there's 12.4 to 13.6 million people in the United States that have latent TB infections. It's about 4 to 5% of our patient population at the time of the study, and 73% of these latent TB infections are non-U.S. born persons. And of these people, that treatment for latent TB infection occurred in 19% of U.S. born and 10% of non-U.S. born persons. So this is where our reservoir exists. When we go to our state level, in 2017 in New Jersey, there was 283 new cases reported for a case rate of 3.2 per 100,000. It was actually a decrease from 2016. And 84% of these were in foreign-born New Jersey residents. 18 of the cases were in children and adolescents. And 10 of the 18 were in children in 0 to 4 age group. And this was the highest amount since 2010. And looking at our state at a national level, it ranks 7th for TB case rate. We're actually 3.2, and we're tied with Massachusetts and Minnesota. and these states are actually the first top 6. If you just look across the board, they're in different parts of the eastern and western part of the country. Looking at TB morbidity by race and ethnicity in New Jersey from 2009 to 2018, the blue bar represents our Asian population, the green is our Hispanic population, our Black population is by the red line, and our white population is by the purple line. And if you look from 2009 to 2018, you can see that our Asian population has really been studied throughout the 9-year period. As you can see, the Caucasian population is actually decreased, and our Hispanic population has fluctuated, but has actually decreased comparatively. When we look at our case rates, I thought this is really important to show, is that it's important to know where you live in what county. I'm looking up to work with Dr. Wenger and Feja, who work with the Middlesex and Hudson TB clinics, and in our county, we see the most cases in the Hudson County. And you can see what part of the state you live and work in and look at the TB case rate. This was over 2014 to 2018 period. So why is screening important? A diagnosis of latent TB infection in a child is a public health sentinel event that suggests there's a recent transmission. The goal is to eliminate TB reservoirs or patients with latent TB infection, and that's why it's become an increased priority for both WHO and the CDC, and to eliminate TB disease. We know in the United States, most of our TB disease is actually from latent TB infections when they have reactivation of their disease. And this is just a graphical representation that the WHO came for World TB Day this year. It's time to put the accent on the urgency to act on commitments made by the global leaders to scale up access to prevention and treatment, build accountability, ensure sufficient and sustainable financing for research promoting an end to stigma discrimination, and to have a people-centered TB response. So targeted TB screening is what's recommended for our patient population. It reduces unnecessary testing, evaluations, and treatments. It identifies persons at high risk of infection with mycobacterium tuberculosis, and identifies persons at high risk of progressing to disease should they be infected. And these are patients who have diabetes, chronic renal failure, malnutrition, congenital or acquired immunodeficiencies, and children receiving TNF-alpha antagonists. We know from past the use of general screening failed because of the low prevalence in the patient population, that there's a lot of false positives, and that will lead to unnecessary testing and treatment. So when we look at the risk of TB disease progression stratified by age, as you can see here, less than 1-year-olds have the highest rate of disseminated tuberculosis and tuberculosis meningitis, which is why BCG vaccination is still used throughout the world. These patients have a 50% risk of reactivation, disease progression associated with high rates of morbidity and mortality. And as you can see, the rate decreases in terms of the disseminated tuberculosis, pulmonary disease, and the fact that they have progression, their risk decreases. So it's as low as 1 to 2% and greater than 10 years of age. And these children tend to present like adults with pleural effusions or pleuritis. These are more with 2% for children who are in school. That's why we have safe school years, is 2% is their risk of progression if they get exposed at that time to disease. And who's at risk for tuberculosis? So we know recent immigrants from endemic countries, recent exposures to infected adolescent or adult contacts. So it could be a visitor just coming for a 2-week period of time, or a household member like a grandmother coming to visit a newborn. Travel, we know, is a significant risk factor, and those could be also in terms of visitors coming in and also visiting those endemic countries, or visiting friends and family is a common occurrence in our state, because a lot of families visit India. I think that my favorite question is when I ask family, have you ever traveled? And they say no, and I'm like, never, whole life, never left the country. Oh, we went to India 2 years ago. I'm like, well, that's really important for history, for the risk factors, and especially asking them what, in terms of if they were born in another country. Children who are immunosuppressive medication is important. Remember, there's newer monoclonal antibodies on the market that are being used for different indications, as well as patients on chronic steroids. It's interesting also, a new article showed that parental nativity, so where parents are born, is important to TB risk factors for the child. So if a child has 2 parents born outside the United States, the TB incidence rate they found was 8.5 compared to 1 parent being born outside the United States of being 3.5. Versus just having 2 US-born parents, the incidence rate was 1. The AAP encourages us to use this Validate questionnaire for TB screening, and it's as follows. Has a family member or contact had tuberculosis disease? Has a family member had a positive tuberculin skin test result? And I'd add here an IGRA. Was your child born in a high-risk country? And these are countries other than the United States, Canada, Australia, New Zealand, or Western or Northern European countries. Has your child traveled to a high-risk country? How much contact did your child have with the resident population? And I would add, you should reassess this with each trip. And I'll also add that immunosuppression and HIV is actually an indication for annual screening. So remember that if patients are getting transplanted, you prepare pre-transplantation, or afterwards is to assess or plan immunosuppression. There's validated tools I will show you at the end of the talk that New Jersey is also developing a specific pediatric risk assessment tool. So in terms of diagnostic testing, we use the tuberculin skin test or tuberculin purified protein derivative, or PPD for short. We prefer that TB experts recommend to use TST as instead of the PPD. The preferred test for children for less than 2 years of age. We know that TST becomes reactive between 2 to 10 weeks after the initial infection, with a median time of 3 to 4 weeks. And then we have our interferon gamma release assays, which are newer on the market. And these measure the ex vivo interferon gamma production from T lymphocytes in response to antigens specific to the Mycobacterium tuberculosis complex. And it uses antigens not found in BCG. The 2 on the market is the quantiferin TB Gold Plus, or the T-Spot TB. And this is the preferred test for all children greater than, that are 2 years and above. And I use this a lot of times in my discussion with parents when they say, well, the child received the BCG, and I think this is a better test that at least you could tell a family that this has no antigens that are found in BCG vaccine. So when we look at the AAP figure here that talks about TB screening, they do suggest that a patient, when you have a BCG vaccinated child, you can determine whether or not they're going to likely return for TST screening here and reading, and if TST is acceptable, but so is an IGRA. And what I wanted to point out, and I made a box here, is that if the IGRA is positive, we believe you treat it as a latent TB infection if you ruled out disease. And if it's negative, it's negative. If it's indeterminate, what's recommended to repeat the IGRA. And if the repeat testing is positive, then you treat for latent TB infection. If the repeat IGRA is negative, you completed your testing. So looking at TST, if this is your preferred test in patients who may be immunosuppressed and at times, or if you cannot use the IGRA, or in your child who is less than 2 years of age. And if we look here, anything less than 10 millimeters in duration is children who are in close contact with a known or suspected contagious person, child who themselves have tuberculosis disease or suspected to have tuberculosis disease, or children who are receiving immunosuppressive therapy or with immunosuppressive conditions such as HIV. Children with a TST and duration of 10 millimeters or greater are those at high risk of disseminated tuberculosis disease. So these are children that are younger than 4 years of age, children with chronic medical conditions, including our oncological conditions like Hodgkin's disease, lymphoma, diabetes, chronic renal failure, and malnutrition, as I mentioned earlier, and children with a likelihood of increased exposure to tuberculosis disease. So these are why our targeted TB questions we have children born in high prevalence areas, or they travel to the high prevalence areas, and children who frequently exposed to adults who are HIV infected, homeless, incarcerated, or live in nursing homes, or users of illicit drugs or IV drug users, if you're able to elicit that history. And the duration of 15 millimeters or greater is in children 4 years or older without any risk factors. So following this algorithm, we have a child with a positive TB test. We're going to follow this algorithm here, where they're asymptomatic, have a normal exam. At this point, you would order a 2-view chest X-ray, AP and lateral, and review it with your pediatric radiologist, which we find is very helpful. And if it's negative, at this point, you would start your latent TB infection treatment, which we'll talk about. The other algorithm I just left here is in terms of this is assuming that we've ruled out patients with TB disease that have symptoms as mentioned here in the box. But a combination, we know, of epidemiological, clinical, radiologic, immunologic, and laboratory evidence is consistent with a diagnosis of TB, then an accurate diagnosis is possible. So it's in combination with all of the information that we're discussing that it's possible to diagnose a patient. So treatment initiation is important to have a discussion with the family and the patient, depending on the age, to counsel and educate them on the patient's risk for progressing to TB disease, emphasizing the benefits of treatment, and assessing whether patients are willing to be treated for the full course of the full treatment. And I have this discussion on consult. Sometimes the pediatricians will send them to clinic and they're like, they're not listening to me, can you try? And I tell family, like, we don't have to make a decision at this visit. We're going to discuss all our options. I give them handouts to read, and then I ask them to come back to me with a decision, because they have to understand that we're committing to this path and they have to continue on that path. If they're unsure at the beginning, I don't want them to start and stop medications as we go. And a lot of times some families do decide, no, just give me 5 minutes, doctor, come back. And some families do actually go and I'm like, come back in a month or come back in a week, whatever time you need, but you need to come back and see me so we can decide the treatment. It's also to assess in terms of, we also encourage you to have that discussion with them that latent TB infection treatment is 90% effective. And that sometimes helps families to understand that as well. We know that routine blood work is not recommended, and the patients will look forward to that. And also it's important to determine if exposure, if you know a patient was recently exposed to, say, a grandfather that had disease, was whether or not their isolate was susceptible to Mycobacterium tuberculosis and not MDR TB, because your treatment regimen would change. So in terms of treatment regimens for latent TB infection, we have 3 that we'll talk about. INH rifapentine is the abbreviation here. The duration of therapy is for 3 months. It's given on a weekly interval, and the minimum doses is 12. Rifampin, as abbreviated here by RIF, is given over a 4-month period of time on a daily basis, and the minimum doses is 120. INH is, there is a regimen for 6 months, but the experts recommend using INH for 9 months daily. And this total count that you have to do for treatment to complete is 270 doses. We count the doses. It's important for treatment. So for treatment option 1, rifapentine, 3-HP, and plus INH. The dosing I'll talk about in the next slide because it's a little different. This is recommended both at the same time, INH and rifapentine. And you also give vitamin B6 as well. This is approved for ages 2 years and above because there's no good pharmacokinetic therapy for children less than 2. The formulations of the medications come as INH 100 milligram tablets and 300 milligram tablets that are scored, and rifapentine comes in 150 milligrams in blister packs, which is important, which you'll see in the next page. And the side effect profile is similar to rifampin. The completion of this medication is 12 doses within 16 weeks. So in children 2 to 11 years of age, what's recommended is INH, and I bolded it because it's slightly different, is the dose of INH to use is 25 milligrams per kilo, and the max is 900 milligrams maximum dose. And rifapentine, the dose is similar in both groups. So these are your 12 years and above, and this is your children 2 to 11. So if you notice, the rifapentine dose is the same for both age groups, but the INH differs from 25 milligram per kilo to 15 milligram per kilo. And as I will show you in the next slide, it's a little cumbersome because if you have a child who's 10 kilos, you have at least 2.5 pills, but it can be up to 10 pills in some children, which is a con of the medication. But this medication can be given by 2 methods based on the local practice and risk of progression. I don't have much experience with that, but Dr. Wenger does, as well as some experience Dr. Feja has. This can be given now by the CDC recommends we can do, instead of doing, initially it was approved as directly observed therapy, but now some centers are doing self-administered therapy. It depends on the local practice. I would check with your local Department of Health as well for their experience, as there's been success with these medications using the self-administered as well. It's important to check with your local pharmacy for the availability and for cost. And the pros of it is that it's great. It's 12 weeks. Families love it in terms of it's like they're done. It's once a week medication that they take. studies have shown the increased adherence and completion rates of it, and it's effective as compared to the other medications we have as well for latent TB infection treatment. And this is recommended, as I mentioned earlier, for just 2 years and above. The CDC has created this nice document here, a medication tracker, which you can give to your patients, and they encourage families to bring it back with every visit so they can make sure that they're not missing any doses. Treatment option number 2 is rifampin, or 4R. The dosing is 15 to 20 milligram per kilo per day, given orally. The maximum is 600 milligram dose. The formulations is 150 milligrams and 300 milligram capsules. It's given on an empty stomach. In children, we try to do the dose similar to as close to the capsule. What's recommended is to open the capsule and to put it in some soft food, whether it's pudding or applesauce, and just a small amount to make sure that the child gets the whole dose. Associated side effects is nausea, vomiting, abdominal pain, orange discoloration of secretions or urine. Contact lens staining could be permanent, and remember, this is the same side effect profile for rifampin. Rashes, thrombocytopenia, pruritus, and influenza-like reaction. It's also important, like rifampin, you have to monitor patients that are on oral contraceptive pills because their effectiveness can decrease, as well as other medications. For example, if they're on seizure medications, you definitely want to check the interaction with the medication before prescribing, having a discussion with the families. The completion for this medication is 120 doses within 6 months. Option 3 is INH, 9H is the abbreviation. It's 10 to 50 milligram per kilo per day, given once a day, maximum of 300 milligram dose. The formulations are squirt tablets, as I mentioned earlier, of 100 milligram and 300 milligram tablets. The side effect is mild liver toxicity, peripheral neuritis, hypersensitivity. It's given over a 9-month period of time. And I found some families, when I mentioned the different regimens, they tend to, some families prefer this because it's been studied longer and there's more experience with that from family members when they start talking to them. It's important at this point also to remember to ensure the index case has an INH susceptible isolate, and if not, we have to use alternative drugs that you can call your local pediatric ID. And the completion for this is 270 doses within 1 year. For medication monitoring, it's important to review common side effects, establish treatment and monitoring plan, as I mentioned earlier, and have the families follow up with you every month with either a physician or a nurse in your office while they're on medication treatment. And fill the prescriptions only on a monthly basis to ensure the families come back and you have a discussion about the above conditions. Patients who have missed doses, it's important to extend or restart their treatment if interruptions were frequent or prolonged enough to preclude completion of the regimen. When treatment has been interrupted for more than 2 months, patients should be examined to rule out TB disease. And we recommend and arrange for directly observed therapy as needed to ensure completion. So some children or some families are not unable to follow it, so it's important to discuss that with your local Department of Health. Clinical monitoring. You have to instruct your patients to report signs and symptoms of adverse drug reactions such as fever, headache, rash, anorexia, nausea, vomiting, fatigue, weakness, dark urine, persistent numbness in the hands or feet. And the monthly visits should include a brief physical exam and a review of the rationale for treatment, again, adherence with therapy, symptoms of adverse drug reactions, and plans to continue treatment, and again, the medication renewals. I put this CDC picture here which I'll try to show you at the end of the talk, which is really helpful and I give to my families when we start medications, is because it goes over while on this medication, what to mention to your physician, tips to take your medications, when to stop your medications, and at the bottom of it, they actually have the name of the physician, the treating physician, and the office number, so you can give that to, say, the school nurse if that's what you have to do with the medications, is they can copy and go with, or say, for example, they're divorced families and the medication's half at their father's house and half at the mother's house, at least they have the same information about that and always to call with any questions. The BCG vaccine is derived from Mycobacterium bovis. It's given routinely in most countries outside of Canada and the United States with a high TB prevalence, as I mentioned earlier. It prevents TB meningitis and miliary disease in young children, and that's why it continues to be given to this day. It's really important to educate our families so that it does not lead to lifelong immunity against Mycobacterium tuberculosis, nor does it prevent primary infection. And this is in red because we get this question very often. We get this often enough that it's something that we want to stress to our families, and I encourage you to do the same. And we know with patients who received BCG vaccines that the IGRAs are better in those who are 2 years and above. So switching gears to window prophylaxis. So we've talked about the epidemiology. We talked about our epidemiology on a global scale, the national scale, and our state level. We talked about diagnosis in terms of TST, IGRAs. We talked about the different treatment regimens the AAP recommends. And then we've talked about what to do in your visit when you see your patients, either on a weekly basis if they're doing the 12-week regimen, or if they're doing rifampin 4-month period of time, and also INH. And we talked about what to discuss with them. So now we like to talk about window prophylaxis, which is still very important for us to discuss in this talk. And window prophylaxis is defined as the prophylaxis to prevent progression to TB disease due to a recent exposure to a contagious TB-infected person. And this is important because it decreases the risk in terms of this is a prophylaxis. So patient at high risk of progression to disease is children less than 5. And like I mentioned earlier, infants and younger children are more likely to develop meningitis and disseminated disease. And it's important to assess the symptoms, physical exam, and obtain a baseline TSD if they're less than 2 years of age, or IGRA if they're greater than 2 years of age, and a 2-view chest x-ray. So we would start INH on a high-risk contact who is asymptomatic with a negative TB screen, so that either TSD or an IGRA, with a normal exam and imaging. And children under 5 years of age or immunocompromised children would fit into this category. And it's important if you have any questions also to discuss this with your local Department of Health, because they would normally be part of a contact investigation of the TB-infected person to get more information. And in terms of what's recommended after you place a patient on INH, if presuming that, for example, that everything's been negative, this patient, you repeat the testing in 8 to 10 weeks, because it takes 8 to 10 weeks after infection for the TSD or the IGRA test to be positive. And this is defined as after the last exposure to the infected adolescent or adult, or after the end of the infectious period, which is determined by the Department of Health. If the repeat TB testing is performed and negative, the patient may be taken off INH. And if the repeat TB testing is positive, it's important to reevaluate and treat for latent TB infection. Immunocompromised close contacts is recommended for them to complete a full course of treatment independent of their testing, as it may be unreliable. So what to do after you've done everything, the treatment of latent TB infection. Most of our patients actually really look forward to this part. It's when we give them the card, which is here. We monitor what to do afterwards. If the family asks you, well, we've complete treatment, what to do, doctor? Like, I'm going to go back to India next year. What do I do? I usually have that discussion with them about making sure maybe the family there gets tested before they arrive, just to have more of a discussion about tuberculosis as well. And at that point, you just have to monitor and rescreen patients based on symptoms, as we don't have any good diagnostic tools at this point to screen patients for active disease after they have a positive TB screen. We don't recommend TB pretesting if it's already positive. And as you can see, the record here of treatment completion mentions the type of test that was positive, the medications when it was started, the time it was completed, the medications that was prescribed, and then a nice disclosure statement here that this person is not infectious. He or she may always have a positive TB skin test, so there's no reason to repeat the test. And then putting your signature here and date and making copies and putting it in their chart, so that way the family knows that they completed the therapy if there's any further questions to ask you. Switching gears to billing. I think it's important to talk about so we actually can document this in our charts. And important for counseling. So in terms of, these are the CPT codes for the Mantoux tuberculin skin test and for the interferon gamma release assays if they're performed in your office. These are very specific tests. A lot of times you'll find that they're time sensitive. You know, we've called LabCorp before, and now they have a courier where the patient gets the blood work drawn, and there's a courier that's called to make sure that the blood sample is picked up from the patient. This is a test that has to be inoculated, incubated in a certain time frame, and we find patients who have like indeterminants. Once you start asking questions about the testing method, you find that there might be issues with that, and it could be multifactorial. So that's what we find to make sure to speak with the lab if you're having issues with the say the IGRAs that you are ordering. The ICD-10 codes. So I wanted to discuss these because this is important. So if you're doing any TB screening, you would use the Z11.1 encounter for screening for respiratory tuberculosis as part of your documentation. For travel counseling, which is also important in patients when they go back to any endemic areas, for example, of typhoid, malaria, and TB, is to use these other codes that can be used for travel counseling. For latent TB treatment visits, the important code that you can use is, like, say that you have a patient is a recent exposed child to tuberculosis. This is the code that you would use, the 20.1. That's why I highlighted, I put it in red. These are a lot of times with patients that we meet that have positive TB screens, whether it's the TSC or the IGRAs. These are the codes that you would use in your billing. So future directions. The reason I wanted to mention this is the CDC is developing a TB latent infection surveillance system, or TBLIS, and that's why I think it's important to incorporate screening and treating for latent TB infection into your normal routine, because in the future we will be reporting this likely to the Department of Health, because the CDC is trying to capture the data now using a surveillance system, but the hopes is in the future we might report, and I think in the hopes in terms of that will help us document any other educational interventions we need to do to help get our patients treated and screened appropriately. So our take-home messages for today is to remember to screen your at-risk patients, traveling, and those patients who are traveling, and foreign-born children. Treat latent TB infection because it prevents TB disease, and remember that people are likely to develop, as here in the infographic by the CDC, they're most likely to develop TB disease within 2 years after infection, and to use your IGRAs for children who are 2 years and above, and to treat with the newer, shorter regimens, which I hope that you feel more comfortable with after today, and also to monitor patients monthly while on treatment. I think it also, going back to the medical home, encourages you to have that discussion with families in terms of their risk factors and if you can modify them. The support for this and the MOC is, as I mentioned earlier, is by our Children's Hospital here at St. Peter's, the Rutgers Global TB Institute, the American Academy of Pediatrics, and financial support from the New Jersey Department of Health. We ask that you fill out the evaluation to obtain your CME and MOC credits at the end. I will give you all the resources that I used here, which I'll show you in a minute, later today or tomorrow. And also please be a lookout for a follow-up survey in December of this year, as we'd like to know if you found this educational intervention helpful. The resources that I have here, as mentioned for physicians, is the Rutgers Global TB Institute has a great pocket guide that they're working on updating next year, and that's great for you. I would say be on the lookout. We can help let you know next year. It has all their treatment regimens and kind of a summary of what I had mentioned earlier about rifampin. And I think it's a lot of questions if the patient has interrupted doses, or how many doses is really important, for example, for completion. There's also a script here from the San Francisco Department of Health I thought was really helpful if you don't feel really comfortable, or say you have ancillary staff that are working with you in your office. For explaining why it's important to treat for LTBI. There's the completion documentation, which you can print in your office, the medication tracker for if you're using the 12-week regimen. And the other thing also is sometimes if you have, say, availability in your office to have an audio-visual videos that you can share, the CDC has different types of personal stories that you can have going in your, I would suggest looking at, or perhaps giving references to your families who are reluctant to treat. I wanted to mention this. This is developed by the California Department of Health, and this was mentioned in one of the articles I mentioned earlier. And I thought it was great that I know New Jersey they're working on one, which would be great. But this is a pediatric TB risk assessment tool, and it's you can actually go to this link and get this as well as the additional material they have there that explains everything. But I thought it was a great summary of everything. It has birth, travel, residence in a country with an elevated TB rate for at least 1 month, or some of us say less than 2 weeks, for example. I mean 2 weeks and above. But it's also based on what their exposure was at that time. Because remember, TB can be in the air; it's airborne, and it could be in the air for about 2 hours. So it's not necessarily just the time. It depends on the time, the duration of their visits. And it has all the high-risk areas that we taught in terms of low-risk states, countries, and then immunosuppression could be current or planned, close contact of someone with infectious TB disease during lifetime. So it suggests at the end, treat if latent TB infection results positive and active TB disease is ruled out, and then if not, no TB testing is recommended at the time. This is the graphical paper I was trying to describe to you earlier, that they're available for all the medications I mentioned earlier. It has the stop sign here for them to pay attention to the side effects profile medications, what they're supposed to look for. While on those medications, what their responsibilities are, tips how to take your medications. A lot of times we'll tell families, put the medication, for example, on the kitchen table. If there's like it's a safe place to put them, but there's no small children, or put it in your sock drawer, as one of my mentors said. You put it in a sock drawer, you're going to always change socks or underwear, for example, something that you do every day, brushing your teeth, and that way there's a reminder set there, or putting it on your phone, an alarm, that you make sure you take the medication at the same time every day. And it has medications, the number of pills per day, the length of time, and then the name of the physician, so that way that can be shared with any care provider. And these are resource specific for patients, which you can share. I just wanted to point out these are specific regimens, which I just mentioned for the patients in terms of INH or FAAP, why testing is important. The CDC has a great website about latent TB infection that's just been revamped, so we'll share that as well. The AAP also has on healthychildren.org a nice page link about tuberculosis, and our state Department of Health also has a great handout on TB. List of clinics I just wanted to briefly mention, because I do have family members who have mentioned that there is an exposed contact who is not a U.S. citizen or just visiting temporarily and is going back home, but they want to get them screened, and their questions are like, where do I go? So there's some CVSs that offer these minute clinics that offer tuberculin skin tests. I don't know the quality of that. I just know that they exist. There is also, I would just recommend contacting your local Department of Health because different chest clinics or TB clinics might have grant funding to pay for screening and testing across the board. And we did find out from the Vaccine for Children program in New Jersey, they can get the TST testing for free. I don't know if there's additional charges for the visit, but it's just something that for providers to look into. And for any questions, you can email me here or email the Global TB Institute at the following address. And for now, we're going to turn it over to our TB experts. I'm going to pull the question and answers and see what questions you have.
Good. Great job, Sabah. Very nice job. Let me just several points just to review. One, we now, especially Hudson County, and Dr. Becker certainly talk about what goes on in Middlesex, but any person over 2 years of age gets an IGRA. There are problems with TST, tuberculin skin test. One, they're inconvenient. It requires coming back 2 days later. Two, the inexperience now even in healthcare workers, placing it is difficult. And reading it is often misinterpreted. It's not erythema, it's induration. And as we use it less and less, people become less experienced. So the IGRA is it's a one-time test. It's much more, and at Hudson County, 2 and above, and often under 2. Well, we often supplement TST and IGRA. We use that. That's 1. So IGRA over 2, BC, whatever. That's what we do at Hudson County. 2, a point about the immunosuppression that Sabah brought up in testing immunosuppression. Remember, screening in immunosuppressed patients is less sensitive than it is in others. So it's important to know that a negative is not necessary. You have to look with a high index of suspicion, giving signs and symptoms, the epidemiology, the exposure, and so forth. So, and try to get, if a child is going to start on biologicals like tumor necrosis, alpha tumor necrosis, suppression factors, that you obviously do the testing prior to starting the initiation. And you could use a TS, but they're both not, it's an index of suspicion. In HIV, if they have a good CD4 count and everything, it should be reliable. As the CD4 count falls, you have to be suspicious. If there's any questions concerning that, please do not hesitate to contact us. And the third point I'd like to make, it's very important if you know the contact, and you often don't, is to find the isolate from the contact and the susceptibility pattern. If it's MDR-TB, you should really then, that's a whole lecture, a whole day in and of itself. But I would recommend contacting us or contacting the Global TB Health Center for direction in addressing those issues. But it's if you know the contact, there should be a great effort in finding what the susceptibility pattern is of the TB isolate. So those are just 3 things that came to mind as I was listening to this very excellent presentation. Dr. Feja?
This is Dr. Feja. Great job, Sabah. A couple just minor points that I always tell patients if they come back monthly to bring the bottle with them, just so you can count the pills. And regarding the side effects, I tell them, if you see any of these side effects, stop the medication and then call us. So they don't have to wait for us to say, stop the medication. Just stop it, and then we'll figure it out afterwards. At the end of all latent TB infection treatment, I also just say, these treatments are very, very effective, but they're not 100%. So in case later the child develops any fever of unknown origin or signs and symptoms that just don't make sense, then people should think of TB as part of the differential. I see that we have a couple questions here about what to do with children who are tuberculin skin test positive, but they turn out to be the IGRA negative. And in those cases, as long as you have a normal physical exam, no signs or symptoms of tuberculosis, we will accept the IGRA results over the tuberculin skin test and not treat them. Again, still saying, in case you develop signs and symptoms of, tuberculosis, then just to think of it.
Right. Just one caveat, it's also age dependent.
Yes.
If they're under 2,
Exactly.
I would do both. If either one is positive, I treat it. Even if they're symptom negative, obviously, and you think it would be LTBI. But it's age dependent. If they're under 2, I take either one seriously. Again, it's different if they've come from a high endemic country, have received BCG, TST often it's generally positive more often the closer you get to the BCG. So it complicates things somewhat. However, I often, because the treatment is really, the side effects are not, the adverse effects of treatment are not terrible with LTBI, I tend to be conservative and treat. But that question is, if they're over 2, I go with the IGRA. If it's under 2, you have to look into it a little more.
Right, and we've seen pediatricians using IGRA just sort of across the board in 1-year-olds, you know, smaller kids. That if you just use an IGRA, if you get a negative, that does not rule out TB infection. So if you have a positive in a less than 2-year-old, you can believe that, but a negative does not rule out TB infection. We answered that one. And then what are the next steps if you get an indeterminate result with an IGRA? And basically then we repeat. I tend to wait a couple weeks and we just repeat it, and then hopefully the next time it's going to be either a positive or a negative, which then you're going to believe. If it comes up indeterminate again, which occasionally does happen, then depending on the epidemiology, I might do a tuberculin skin test in that case, or basically treat based on, you know, the signs and symptoms and risk factors.
Yeah, it's important to know which IGRA you're using. The old IGRAs were very dependent on how the blood was collected, how soon it was sent, and so forth. So you have to make sure. There are several different IGRAs. Sometimes I recommend using a different IGRA. If you get an indeterminate, try a different test or the TST. But there's several reasons you may get indeterminates, and one of those is the handling of the product, where it's done. Now, IGRAs can be expensive. However, at the I'm sure Middlesex and Hudson County, they're free to the patients. You can get the IGRA done at those facilities if required.
But if your patient has insurance, then by all means send them to LabCorp, wherever. They all have the QuantiFERON is now switched completely over to QuantiFERON TB Gold Plus. So I don't know of any places that are still doing the older versions of the QuantiFERON. They all have the newer versions. Okay, any other questions from anybody? Please feel free to type your questions in.
One thing I found when I was at the I worked with the Board of Health in Newark. We did a survey. We looked at practices, and we found there was a recent, I forgot who just did it, but they found that over 40% of the births, at least in the Newark hospitals, and certainly I saw one for northern New Jersey, over 40% of the births were children born to parents who were foreign born. So New Jersey has a high, and this is what makes New Jersey a great place to live in. It's very diverse, and it has a high, a large population of recent immigrants. So it's important to know, and I'm sure you all do, is the makeup of your clinic. We found sometimes a little question. We did in this survey, again, that over 40%, almost 50% were children were born to foreign-born parents in this area, and that over 80% had visited their country of origin within the last 2 years, over 80%. Now, so I think it's important to know your populations that you're treating and to be proactive and to really offer them, you know, the travel information that's often necessary for those particular countries, and also to test, again, for TB when they return, because they often, you know, return.
And just make sure at every visit, are you planning to travel anywhere? If you ask your patients, often if we ask, oh, have you traveled recently, they say no. So I always ask the question is, have you ever been outside the United States? Because otherwise the information may not come out. And I know it's extra work in a short visit, but that's a great screening practice.
Yeah, it's also good to, if a little questionnaire. Do you visit, you know, how often? And it gives you sort of a heads up in general, and you find that it's actually very common. And again, it's people going back to visit their homes. They often don't think of that as travel. So it's important to ask it in several different ways.
Want to do that?
I can't see it.
So the last question, or another question, is if the IGRA is positive, will it always be positive after being treated for LTBI?
Yes.
So the answer is yes. And that's why at the end of the treatment documentation, it actually states that. And then I always tell patients, do not get retested,
Right.
because your test, whether it's a tuberculin skin test or an IGRA, will continue to be positive for many years.
You'll often find that people who have had positive, when they go to different, like they go into college eventually, they're going to be asked to get chest x-rays. And if they're often questioned if they have symptoms, and then they're evaluated again. But as Dr. Feja has said, the tests are always going to be positive, so they're not going to be helpful once they become positive. But again, in indexes, you have to still evaluate the signs and symptoms at every encounter, and often for jobs, for joining the military, all these things, they may be asked to get chest x-rays.
But I always tell the parents, keep this letter, the
That's
treatment completion letter. This is one of the most important letters you're going to have, because you have to keep it when the child goes to college or wherever. Okay, next question. Is there any benefit to continuing LTBI treatment after the window prophylaxis, second negative TST? I'm hearing talk of this, and there's no other reason to continue. So if the second test is done at an appropriate time, meaning that it's 8 to 10 weeks after the last contact with the infectious case, or after the infectivity period is over, and I would say the child is over 3 to 4 months of age is when the TST sort of starts becoming a good test, then there's no reason to. If the child is immunosuppressed, if there's other reasons that, you're not believing those tests, then absolutely I would continue the full course. Another question? Was there? Nope. The answer is sorry. All right. These are all excellent questions. Anything else from anybody else?
Hi, Dr. Feja, and Dr. Wenger, and that was a really good presentation today. This is Patty, the nurse consultant for the TB program, and I just wanted to say that for anyone that is looking for IGRAs to be done in the local clinics, just call your local clinic, because we are opening up more and more resources to other clinics that maybe didn't have them in the past. So I would really just check with your local health departments. And the other question that I get a lot is when they're getting live vaccines, can you just speak to that about the difference, like with the TST, can I get the TST at the same time, or the IGRA as the live vaccines, or afterwards?
Again, the vaccine they usually talk is the MMR, because there's a theoretical, but that the measles virus or any live virus will actually suppress the immune system. I'd recommend if it's an inactivated vaccine, it's fine to get the and again, if it's over 2, the IGRA. If it's MMR or varicella, we'd give it a month. Wait till a month after the vaccine.
Or the same day.
Or the same day if you're giving the vaccine. That's right. We usually see in the clinic they've already received it. So that's right. Either give it the same day or wait for a month after either live virus vaccine. That's MMR and varicella. Inactivated, it doesn't matter. Is that okay, Patty?
Yes, thank you. Thank you.
Okay.
Anything else?
And if anybody ever has any questions, you can call any of us.
Yeah, absolutely. Don't hesitate in calling. For some of this is very tricky.
Yeah.
And it can be very difficult. So please don't hesitate to call.
I think if we have no more questions, we can conclude the webinar. As mentioned, if you have any additional questions, please feel free to email Dr. Kalyoussef, or you can email the NJ chapter and we can forward them along to Drs. Kalyoussef, Wenger, and Feja.
Great.
And then we'll send you the resource information that I mentioned earlier in email so that you can use that in your daily clinic and incorporate it into your routine. Thank you.
Thank you.
Thank you.
Thank you,
Pleasure.
everyone. On behalf of the New Jersey chapter of the American Academy of Pediatrics and the Rutgers Global Tuberculosis Institute at the New Jersey Medical School, we'd like to thank you for joining us on this webinar today. Thank you and have a great day.